All right, good morning. Welcome to the Gennev Painful Sex webinar. It's 9 a.m. straight up. I'm Jill Angelo. I'm the CEO of Gennev. Looks like we have about a number of attendees joined, and I think that number will go up as we get into the first few minutes after the hour, but let's go ahead and get started. First of all, welcome. This has been a fun event to put together. Sex and sexual wellness is probably one of the most important and frequently brought up issues with questions that I get from the Gennev community every day. I am Jill Angelo. I'm the CEO of Gennev, and I'm super passionate about women's health in midlife. And today, as we talk through painful sex, we've got a number of different viewpoints, anywhere from physicians in PhD view and work around sexual health, all the way to some really amazing and interesting and innovative products that can add a little bit of not only enjoyment back into it for people who are suffering from extreme pain, but also a little bit of fun. So we're going to try and make this conversation as fun and informative as possible. Just for housekeeping, this webinar is recorded, and so if by chance you want to refer to it afterwards, if you want to forward it to friends or to people that you know might be suffering from some of the similar issues that you are, please share it about. We'll make it available at gennev.com afterwards. And also, if you want to ask questions, there is a chat window. If you scroll to the bottom of your screen and you see a little symbol that says ... more, if you open that menu, chat is one of the options. And as an attendee, you can go ahead and put questions into that chat window at any time. And Shannon Perry, who is moderating this, will go ahead and flag those questions for us. So we've got an hour of jam-packed information. What we're going to do is go through a number of questions that I've prepared for our panelists. Some of you also submitted questions. We'll go through those as well. But first, I'd like to introduce our incredible panel. We're really, again, excited to have every one of these women join us because they bring such amazing, diverse perspectives on sexual wellness. So I'm going to start off Dr. Sheryl Kingsberg. You want to just raise your hand, Sheryl? Sheryl is a PhD and is the chief of the Division of Behavioral Medicine at MacDonald Women's Hospital and University Hospital's Cleveland Medical Center. Her areas of clinical specialization include sexual medicine, female sexual disorder, menopause, pregnancy and postpartum mood disorders, and psychological aspects of infertility. Dr. Kingsberg's primary research are in the treatments for female sexual disorders and psychological aspects of infertility and menopause. And she's worked with a number of different companies that are working on solutions in this area as an advisor and expert for many of them. She also happens to be the 2017-2018 president of the North American Menopause Society. So thank you, Dr. Kingsberg, for joining us today. She brings an incredible background to this particular webinar. Dr. Rachel Gelman, next up, you want to go ahead and raise your hand. Dr. Rachel holds a doctorate in physical therapy from Samuel Merritt University. She specializes in treating pelvic floor dysfunction in men and women at the Pelvic Health and Rehabilitation Center in San Francisco, where she serves as the branch director. Dr. Rachel has consulted for various businesses, including Gennev, as well as Lioness Health and Ohnut, both who are on the webinar today. So thank you, Dr. Rachel, for joining us today. Next up is Jessa Zimmerman. Jessa, you want to raise your hand and wave at the crowd? Jessa is a couples counselor and sex therapist. She's certified by the American Association of Sexuality Educators, Counselors, and Therapists. She also holds a master's in psychology from Saybrook University. She sees individuals and couples at her Seattle-based practice. And if you're not in the Seattle area and you want to tune into into Jessa's information, she's got a podcast at bettersexpodcast.com. And her website is full of great information for anyone experiencing sexual problems. So thank you, Jessa, for joining us. Liz Klinger. Liz is up next. Raise your hand and just wave to the crowd. Liz is the co-founder and CEO of Lioness Health, the company that brought you the Lioness. The Lioness is a smart vibrator that allows women to see their sexual response and orgasm, giving women the opportunity to track what stimulates or what doesn't, and to see how her body changes over time. The Lioness is built both for increasing pleasure and increasing a woman's understanding of her own body. And finally, Emily Sauer. Emily, you want to go ahead and raise your hand? Emily is the founder of Ohnut and has a personal understanding of painful intimacy. After more than 10 years of enduring painful sex, she decided it was time to find a solution. She spent the next several months designing the Ohnut, a soft silicone ring that's worn on the penis to limit the amount of penetration. Created in her kitchen, the Ohnut is backed by science, vetted by healthcare professionals like Dr. Rachel, and proven in trials, and recently concluded an incredible successful Kickstarter. So if you want to get your order in for an Ohnut, go to Kickstarter now. We're going to hear a little bit more from Emily on that product. And again, Emily, your personal story behind that really just, I think, says a lot around what you're doing with that device. So thank you.
Thank you.
All right. Well, good. Well, to start with, let's go ahead and dive right into the questions that we've gone ahead and pulled together. And I'm going to start with the most apparent one. And that's really all around what causes painful sex. You know, for me, again, as the CEO of Gennev, I hear about this all the time. And my mind automatically goes to vaginal dryness or to atrophy, which a lot of women experience in midlife. But I want to start with Dr. Sheryl Kingsberg. Sheryl, what are some of the other reasons women experience pain with penetrative sex? And if you can go ahead and unmute yourself, Sheryl. We can't quite hear you. There we go. We got you.
So it's a pleasure to be here, and I'm excited to talk about painful sex. The reality is, as you talked about, the fact that many women at midlife are experiencing pain. I don't want to just skip right over that, because we know that in the United States, there are 64 million postmenopausal women. And we can estimate that at least 50%, more like 70%, are experiencing vulvar and vaginal atrophy, which we now call genitourinary syndrome of menopause. Why? Because women don't really like to think of their vaginas as atrophying. Midlife is a time to embrace sexuality, and 60 is the new 40, and sexuality is vibrant. And although young medical students often think that their mothers aren't being sexual, we certainly know that that's not true. So it's important that midlife women not be ignored here. So I don't want to ignore the fact that we've got millions of women suffering from vaginal atrophy, and we have safe and effective prescription products that many women have been scared away from because the idea of the word estrogen, for example, scares them away. So we have a variety of local estrogen therapies that are safe and effective that can actually restore the vagina to its premenopausal state, because estrogen is necessary for vaginal health, and in the vestibule, in the vagina, even in the bladder for some women who are having incontinence-related issues that may be impacting their sexuality. We also have a new vaginal DHEA that has been approved, so there are a variety of options, and there's actually a SERM, an oral medicine, aspemophene, that can also be used to treat vaginal atrophy. So for those 64 million postmenopausal women, we have safe and effective treatments to address the pain with sexual function that's related to the loss of estrogen. But for the rest, there is also vulvar vestibulitis, there's a lot of neurologic conditions, there's lichen sclerosis, there's so many dermatologic conditions, there's a variety of medical conditions. And I will tell you that Irv Binnick has been quoted as saying, is the sex painful, or is there painful sexuality? And the fact is that really this is about looking at the underlying condition. Too many women have been said it's all in your head and just get over it, or this is something about your own discomfort with sexuality, when we usually know there's a medical interaction there. And with that, there can be anxiety and vaginismus, which is the anxiety-related tightening of the vaginal muscles, that can be addressed with cognitive behavior therapy and pelvic floor physical therapy. Thank goodness for that specialty. But I'll let the others jump in. But there are a variety of reasons. I just don't want women to think that they should be blaming themselves for something that often can be treated medically or psychologically.
That's great. Thank you. You know, I think as you were going through all the different options and solutions, Dr. Sheryl, you know, a few questions even came in around, so is estrogen the only option? And I think you pointed out No, no, it's not. I'm going to cue off your point around physical therapy and go there for a second so that, and turn it next to Dr. Rachel, who is a physical therapist on pelvic floor rehabilitation, to talk a little bit about what do you do with patients to help eliminate the pain, probably specifically in some of those that don't have the option or would prefer not to take estrogen-based therapies. Dr. Rachel, can you comment on, from a physical therapy perspective, how you address painful sex?
Yeah, of course. So we're looking as physical therapy.
All right, Rachel just froze up. Here we go. There she's back. All right, we lost you just for a second, so start from the top.
Oh, that's good because I stumbled, so I get a redo.
There you go.
Yeah, so, you know, I definitely see a lot of women and men, but obviously we're talking about women right now. And a lot of them come in concerned about the whole estrogen thing. And, you know, I try to give them guidance on that because there has been a lot of scary information out there. So I totally get that, you know, there's still a lot of concern around estrogen, but as a physical therapist, and as a pelvic floor physical therapist, what makes us unique is we're looking at not only the whole body, so the musculoskeletal system of people.
We'll let the technology catch up. It froze just a little bit again. So here we go. Got her back. All right.
Sorry, I don't know why it's going so crazy when it was fine before. I'm looking at we're looking at the pelvic floor. The pelvic floor are the muscles inside the pelvis. And those muscles support all the pelvic organs. So for women, that'd be the bladder, uterus, colon. And so what makes this unique is we're addressing those muscles internally, as well as addressing any muscles that attach to the pelvis. So I'm looking at the legs, I'm looking at the back, I'm looking at the abdomen. And what can happen is those muscles can become dysfunctional, just like any other muscle of the body. So they can become spasmodic, restricted, hypertonic, or, you know, there can be laxity of the muscles. So everyone always thinks of the pelvic floor becoming weak over time, that we become weak, the muscles don't work anymore, and that's what leads to all the problems we see later on, like incontinence. But in reality, most of the patients I see have the opposite, where their muscles have become restricted. And so we're working on getting those muscles to get back to a normalized state, so a more neutral resting tone, and getting more blood flow into the area and addressing any restrictions that might have occurred over time. And sometimes what happens due to the changes with menopause or vaginal atrophy is those muscles are like, oh, there's something wrong here. You know, we're lacking estrogen, so we need to protect this person. And the way we protect is by, you know, going into, I always describe it as like fetal position, we contract. So sometimes even, you know, the primary cause might be a lack of estrogen, but there might be underlying muscular dysfunction that needs to be addressed in addition to the hormonal dysfunction.
And, you know, can you go into just a little bit of detail around what, as a physical therapist, you actually do to start to release some of those muscles or the restriction that's occurring?
Yeah, so we're doing a lot of manual therapy techniques. So connective tissue manipulation, trigger point release, myofascial release. So it's external treatment, and I always start externally, and then we'll do internal, which is just one lubricated finger inserted vaginally. Although my patients can always opt out of the internal part of the treatment. So usually, I mean, people describe it as it feels like a massage, but a pretty more intensive massage. But we're also doing things like neuromuscular reeducation. So teaching them how to relax those muscles. And that can be with breathing techniques, different mindfulness exercises, which I'm sure Dr. Zimmerman can touch on, because we work a lot with sex therapists and therapists to address that aspect. But, you know, we're trying to teach people how to connect with those muscles, how to relax them, how to activate them if necessary. So it's a combination of hands-on manual therapy as well as re-educating the muscles.
That's great. Thank you. Thank you. Keying off, you know, Dr. Sheryl's initial comments around, you know, in addition to estrogen therapy and physical therapy, there's also psychological and you know, that can be addressed. And so I want to turn this next question to Jessa, our sex therapist, to talk a little bit about your work around the relationship side of the equation for both women and for couples in the work that you do?
Yeah, so in my practice, I do work mostly with couples because this, when there's a sexual issue, it's affecting both people. And there are a lot of ways that the relationship also affects the sex life. So I'm working with people to have the conversations about what is actually happening. Because I think, partly what'll happen first is people start to avoid sex. If it's negative, if it's stressful, if it's painful, if somebody feels like they're inadequate, if you go get the feedback that this is all in your head, you just need to relax, and you're still having pain, people will come in almost feeling broken, right? So we have to change the expectations and let people know you've got a real problem. It makes sense that you're avoiding sex because it's painful. So how do I help a couple have the conversations about what's actually happening? How are they feeling? And then a big part of my work, while they're working on the physical aspect of addressing the pain, is supporting the couple to explore all their sexual options. Instead of taking sex off the table, it's about let's redefine what sex even is. It doesn't have to be penetrative sex. So how do we explore and have connection and pleasure together as much as they possibly can, given what's not painful, while they're still pursuing the medical route?
Great. I think to open up those lines of conversations, it's just so important. And then again, to reassure that it's not just one person or the other. It's a team sport,
Yes.
if you will, if it's couples oriented. So taking it back to around the head and it's just in your mind. I know, Dr. Sheryl, you mentioned early on that sometimes women hear that from their physician. Oh, it's just in your head. Can you talk a little bit about why sometimes women might feel that their physician, if they've gone the medical route, is dismissive of what's going on? I think we need you to go off mute again.
I am.
There we go. Excellent.
I never was.
Okay.
Okay. So I want to reiterate that sex is supposed to be pleasurable, and it's not always heterosexual sex. So it's sex of any kind, and it's not even sex with a partner. So there are many single women out there that need, and I'm sure some of the others who have some devices will talk about sex for one as pleasurable. But with regard to chronic pain, because for most women this has been a chronic problem. They have not just discovered this problem. Healthcare professionals, not just physicians, but HCPs in general, tend to avoid dealing with chronic pain. Number one, they don't know how to fix it. They like to cure things. And so if there's something they can't easily address, they become avoidant as well because they don't want to feel like failures. And oftentimes it feels overwhelming to them. And once you've become somebody who has chronic pain, you often feel self-defeated as well. And so it becomes sort of this dance of avoidance, and you want help, but you're afraid to ask for it, feeling like somebody's going to blame you. So for healthcare professionals, it really is an avoidance of not knowing what to do to fix it. So you need to be able to ask, you need to come in with your functional impairment. I mean, if you really want to get help, you come in with as specific a list of symptoms and onsets, do the work for them, if you will, to make it easier for them to then guide you to help. Because a lot of times a generalist isn't really going to know where to go. We, for example, in the North American Menopause Society and the International Society for the Study of Women's Sexual Health, I'm the past president of that, really try to get the patient where they need to be, or the woman where she needs to be, so that she's not kind of stuck in that chronic pain syndrome where clinicians just avoid and dismiss. So it's really about getting to the specialist. If a healthcare professional can feel like they can help simply by a referral, they're more willing to ask. And it's really about asking, assessing, and then moving forward. That's the key.
I think that's super helpful. And even now, I love how you even walked us through a little bit around the questions that a woman should ask, or how she should be prepared to come to talk to her physician. Can you just go into that for 1 second around you're obviously experienced in asking many questions of the people that you see, but what are some things that the women who are experiencing pain should be prepared to come in and ask about and talk about and feel very comfortable asking about, even if their physician isn't fully prepared to respond in that moment?
Sure. And again, not always physicians. We want to broaden it to all healthcare professionals. Physicians are often the first place you go. You often go to your OBGYN when you have a genitally related pain problem, but it could be your primary care physician or health or nurse practitioner, for example. So you want to come in with as much, again, functional impairment as possible. When did the pain start? Have you always had pain? Did it start? Do you have any sense of what triggered it? Is it generalized to all situations? Is it specific to certain situations? Does anything make it better? Does anything make it worse? What's the level of pain from 0 to 10? Now, a lot of times when you have chronic pain, it feels like a 10, but it can't be a 10, because if you're a 10, you can't be speaking. You need to give some kind of range. And is it better in the morning or at night? What are the things that make it better or worse, to help guide the clinician so that they're not overwhelmed with the sense of, I don't even know where to begin. And especially, and the physical therapist can jump in with the idea of, is it localized to the vestibule? Is it sort of, near the entrance to the vagina? Is it around the perineum? Is it external to the vulva, or is it deeper? And a lot of times women won't know, and a lot of times pain is referred. So you may have, for example, some pelvic floor dysfunction that then comes across as a symptom closer to the vagina. So again, you may say it's everywhere or generalized, but as specific as you can, and adjectives help. Is it burning? Is it stabbing? Right? Is it pressure? Those kinds of functional definitions are hugely helpful, so that you and your clinician are a team, right? It's shared decision making. It's being able to together assess it. It empowers the patient to feel like she's involved in her healthcare, and it certainly helps the clinician to feel like they can help guide them.
That's great.
And can I jump in here?
Please.
I was going to say, sometimes people are often surprised. I ask a lot of questions about, bowel function, urinary function, because a lot of times patients might come in and they've been constipated, they've had painful bowel movements for years and years and years, and they don't recognize the connection between all these different systems that are housed inside the pelvic floor. So, if they've had a long history of constipation, IBS, or maybe they've had a long history of urinary tract infections or things like that. So I'm always asking those kinds of questions. So, don't be surprised if your provider, because people are always like, well, why are you asking me these questions? I'm like, well, it's all connected. And sometimes addressing the gut health can really help with pelvic floor dysfunction overall, and can help, it might not solve all of the issues with sexual dysfunction, but it can be, something they can do, because like Dr. Kingsberg talked about, it can be a process. So sometimes working on the gut piece first can make them feel like they're actually doing something. And again, it's about making them feel empowered. So I always am wanting people to know you're going to be asked questions about some things that you might not expect to be asked about related to sexual health.
I think that's so enlightening that it's so connected, and going even into guts and further, because that whole area of the body is such a mystery to so many people. So I think all those questions and education is helpful, even just knowing. So let's transition to products, because we do have some great innovation in addition to clinicians and your clinical team working with you. In terms of what can you be doing at home, and often using amazing innovative products that have been created to go ahead and really help women explore, and make it more comfortable, etc. So I'm going to first go to Liz Klinger of Lioness Health. Liz, can you talk a little bit about the Lioness and how you've seen it how women are using it to start to improve sexual function, understand their bodies, and even maybe alleviate pain, where they've really worked on trying to address
that? So I guess for people who don't know what Lioness is, I'll do a very quick, here's what Lioness is. So it's basically, so you use the vibrator like a normal vibrator, and then if you have a session that you want to see, where you want to see what happened, you go to your app and you basically see what happened. I don't know if you can see this very.
It's kind of white. It's not showing all the graphics, but what you see is trend lines, correct?
Yeah, you're seeing the trend lines. You're seeing the right now. I'm showing the area where there's the, like, you see the pelvic floor moving. There's the rhythmic contractions that could be the orgasm, or just like other things that your body is doing during it. So like if you were like relevant to this session, like if you're experiencing pain, where might the pain be? Or if you're using the lioness by yourself or with a partner, if you're stressed, if you're relaxed, if you're let's see, I've tried, with alcohol sometimes, or like, other sort of stimulants, and like basically like use it kind of like a sex diary and like a way to automatically track your experiences over time. So where it really gets interesting is you can see how your pleasure changes. Is it better at certain times, or is it worse at certain times? And you can start sussing out like what constitutes a good session for you from a bad session for you. So now that we've gotten that like established of what lioness is, we've been out in the market for about a year now. And even though we didn't intend, like, lioness isn't specifically for painful sex, it's more of this platform to experiment with. We have had some people who have used the lioness to like start like getting a sense of like when are more painful experiences for them from less painful experiences. Like one of our early Indiegogo customers, she had just, bought on the Indiegogo, like the Kickstarter crowdfunding campaign. And she told us that after a couple of months of using the lioness, that she was starting to like keep track of things, like see like when were more painful or less painful times for her, so that she would use that data then to discuss the issue with her partner about penetrative sex. So they were able to try different things together, and it made her feel more in control about like, oh, it's not like all the time. It's only, it's like sometimes these times are more painful for me. These times are less painful for me. And we can talk about it and try these things together. And she's now having a lot less painful sex, which was just like, we didn't expect that, like we didn't design it specifically for that, but that worked for her to be able to try out different things. We've also had people who, like one of the crazier ones that happened recently was we had someone who like wrote into our customer service saying that they had an issue with the software, and that their graphs were not the same, and she wasn't able to find her orgasm anymore. And we did this like back and forth for a little while. And at some point, like, we're just like, okay, like what's going on? Is there something going on with the sensors or the software? Like what's happening? And we discovered that she had recently had a concussion, a sports related injury and a concussion. And it was like happening around the same time that her orgasms used to look like this. And now it's kind of looking like this. And we're just like, could it really be, could the concussion really contribute to that? Like, really? So first we were like, okay, first go see your doctor and, get your concussion treated. In terms of the lioness, let's wait and see for the next, couple months and see if the graphs start changing, because it was not anything that we could see from the software. And then sure enough, after a couple of months, the graphs were looking like this again, which was crazy to us. So we've seen all sorts of things of like people like using lioness to like learn more about themselves, learn more about like what works for them, and even like start understanding the relationship between their bodies, their pleasure, and how that plugs into all sorts of aspects of their lives, and also have fun with it.
That's fantastic. Wow. What incredible anecdotes, as well, of people using it in many different ways. Who would have ever thought, a device could be so informative? So thank you, Liz. I want to do a quick time check. I know we're halfway through the session. And I think, are we going to lose you, Dr. Sheryl? I know you had some other commitments that you had to make. So I want to make sure that we give you a fine farewell if you need to drop off.
Yes, I do need to drop off. So thank you for allowing me to join. I wanted to make one thing, because I saw many questions about estrogen. And while I do agree that pelvic floor physical therapy, psychotherapy, I'm a psychologist. I treat vaginismus, I treat the anxiety related to consequences of pain. But it's so important that the North American Menopause Society, the American College of OBGYN is supporting the fact that local estrogen and local DHEA are safe and effective, and that women should not be so fearful of it. There's very little, if any, systemic absorption, and there's so many ways to treat vaginal atrophy in menopause. I just don't want you guys all going off and thinking that just because there are other treatments for painful sex that we should ignore the fact that local estrogen really is safe and effective. So, you know, with the loss of estrogen, we do want to restore it. So that's my final push. Don't be so frightened. So thank you for having me.
I think that's great. Thank you for joining us today, Dr. Sheryl. And we'll certainly provide your Twitter profile or contact information from a Twitter perspective. We're doing that post-webinar with everybody, so people can certainly direct tweet you and get in contact. So thanks
Great.
again.
And North American Menopause Society too. Great.
North American Menopause Society.org is the website. So
it's actually menopause.org.
That's right. Thank you.
Thank you.
Thank you. All right. Well, while we're talking about devices, I want to turn it over to Emily. And Emily, I'd love for you to talk a little bit about Ohnut. It's a unique device. So I'm going to just let you take it from here because I think what I love about this device is it was created out of your own personal needs. So please share a little bit about the device and how it's working for women and couples everywhere in addition to yourself.
Yeah, it's been quite a journey. I'll say that much. Yay! And Rachel Gelman has been a rock star in my journey. I cannot thank Rachel enough. She is like an advisor of all advisors. She's there in the social media presence and on the educational side and anatomical and information as well. But anyways, yeah, because I essentially kind of started from a totally different industry and moved completely into this one. So there's a lot of education that came in a very short period of time. So Ohnut, if you're not familiar, is an intimate wearable. It's the first intimate wearable that's designed to be stackable. So like Liz, I have my little guy here. It's designed to be stackable and so that you can control the depth of penetration. So the stackable nature is that this comes off. Yay! And then they're really easily restackable here so that it's worn at the base of the penis during penetration and it compresses down essentially during penetrative sex for women who have deeper pelvic pain. So we found that it's helped in a lot of different ways, which is very exciting. So there's an anatomical adjustment, like a fine tuning that happens. But more than that is, well, not even more than that, in addition to that is the conversation that ensues. Because this is a product that is worn by a male participant or is put on, another object that is inserted, it is a couples product that requires couples participation. So it's not, whereas a lot of solutions are a woman kind of for herself, by herself, this is very much a conversation. And by, I like throughout this entire conversation so far, I've been watching everyone nod their heads when they agree with things. And I remember when Jessa was talking and when Dr. Sheryl was speaking about how women think that it's all in their head and you blame themselves internally for a physical pain, kind of transitioning into a sense of character flaw. Really what that does through conversation is it normalizes it. It makes it much more of a tool for creative collaboration as opposed to a focus on the problem. That being said, the Ohnut is also very much can be integrated as a part of a multidisciplinary approach. This is not the be all end all solution by any means. In fact, where I think we are serving a phenomenal purpose right now is really starting that conversation on a ground floor level. We've gotten some media recently that has just bolstered this conversation about painful sex. And you see these videos on YouTube and they've got comments on comments on comments from people who've never talked or never admitted to themselves or never said it out loud to anyone else that they might have had this experience before. And people are like, you've got offensive people who are like, well, your man's going to leave you if you do this. And then the women are all like, what do you they just throw him out the window. So it's been really, really cool to see the responses, because in this conversation, we have a lot of specialists, and it's how do people get to you? And it starts from a place of education and normalization. And that's what we're really hoping to do. Sorry, that was a lot.
Great. No, I love it. I have to ask the question, does it decrease sensitivity for the male or for the one? No. Automatically my mind went to that. And I was like,
yes.
Is your partner sacrificing anything?
Totally. It's so funny because men's and sorry for gender binaries, but the male partner generally associates sexual enjoyment with physical sensation. And so I'll speak to the physical sensation. So if you look inside, actually there are ridges in here. So it's actually quite comfortable. It feels good. And then it's also a little bit like a hug. So there is that sensation of like a vagina extension. So there's that for one thing. But the feedback that we've gotten from the men is that when their partner is really enjoying themselves, it is a whole new sexual experience. It's like when you're worried about hurting someone or you're worried about your partner being in pain, that's like on your side for fear of causing it. And that is then kind of reduced and you can just be in your body, and then seeing your partner also not being afraid of that. It is literally like that disruption keeps that sexual pleasure down. Whereas when you're not so focused on how you're doing or if this is working or, then you can actually just have fun. So the men have been very excited. Also, it can be used for foreplay. And like I had one user say that it's the most romantic hand job he's ever gotten. So
excellent. That's great. Because I think you start to see the creativity that people come away with in
yes.
having fun and not going by, a certain set of whatever needs to be, they get a little bit more explorative. So well,
absolutely.
Good for you, Emily. I just think what you're doing is great. Congratulations on your big Kickstarter. We're going to come back to you because I have another question, but you talked a lot about how about the Ohnut and how it starts to open up a dialogue between two parties that are involved. And so Jessa, I want to go back to you because again, you talk to couples so much and, how much in your practice, obviously this whole topic is taboo. So Jessa, when a couple comes in to talk to you, how do you start to open them up so that they can have a comfortable conversation? Is it starting to talk creatively about using toys or using, I'm not going to answer the question, but how do you start to get them to open up?
Well, I do have the advantage of when people come to be kind of prepared, right? They've contacted a sex therapist and made an appointment. So it's not like I'm randomly talking to somebody in a coffee shop. Although I might do that too. But, it comes to the conversation already. So that's helpful. And it's really just a matter of meeting them where they are. Questions about sex. I'm trying to pace that with their comfort level. I'm trying to use their language just possible to reflect. It's in a room that I'm totally relaxed with this. And so it eases that for them too. And you're right. It is taboo. A lot of people have never talked about sex. I've had clients who've been married for maybe decades, and it's the first time they're talking about sex between the two of them, how they feel about it, that there's been a problem. They've got a very long time never bringing this up. And then once they're over that hurdle of that first conversation, usually there's a lot of relief, because I do normalize what's happening for them, and I am so welcoming, and it's a safe place to have sort of hope that we can actually make this better. And I think that's maybe what keeps people from bringing it up. It's almost like Dr. Sheryl was saying, if people don't think it's treatable or they can't fix it, why talk about it?
Mm-hmm. Yeah.
So once they start and they get a little hope, like, no, this is normal. A lot of people struggle with sex. We're going to be able to improve this. Then they have relief.
Well, and the fact that it is affecting so many people, the numbers that Dr. Sheryl started with at the beginning, 64 million women post-menopause, 50% of them are experiencing some sort of challenge in this. Your calendar must be stacked, but I want to impose upon people that you're not alone, and
Oh, yeah.
this is normalized, as you said, which I think is one thing that you brought up in some of the comments was a book called
Yeah.
When Sex Hurts. Can you talk a little bit about that, because that helps open the dialogue too?
Yeah, it's one of my favorite resources actually for people with pain. So it's not just about, midlife or menopausal pain. It's all kinds of sexual pain for women. It was written by 3 different healthcare providers, and where they disagree, they say that in the book, where they have different approaches. But it really describes every condition that might cause sexual pain. And it goes through treatment options and all kinds of different ideas about that. But one of my favorite parts about it is they have almost like a decision tree. Is it like this or like this? Is it stabbing or burning? Or, and it really helps the reader narrow down what might be the root cause. Because again, like Dr. Sheryl was saying, the more work the patient can do ahead of time and bring into their professional, the better, because there are just not enough medical professionals really trained and specializing in pain. And so a lot of even a gynecologist or urologist is not necessarily well equipped to deal with this. So coming in as a patient, very educated, aware, bring this resource in, share it with your physician or whoever you see, and have a good idea ahead of time. And then my main advice to people is be really perseverant, because you may have to go through many providers before you find one that's going to take you seriously, that's going to be helpful, that's educated, before you get the referral that you need.
But just know there's help. Like there's a better way.
There is help. Yeah, there is. And sex should not hurt. So.
Yeah. And just to kind of jump in there, the thing I was thinking of that I always find interesting is how many patients I see who I ask if they have pain with sex, and they kind of pause and they think, because maybe they're coming to see me for something else. They're coming in for urgency, or like urinary incontinence or urgency, and I ask if sex is painful. And they always pause and think, and they're like, oh yeah, but like that's how it's always been, or that's normal. So I think when I hear these numbers and percentages of people who experience pain with sex, I always think it's probably lower than it actually is, because so many people actually experience pain with sex and they don't realize that that's not how it should be. And I even talk to so many friends and family members, and when I talk about what I do, and they're like, oh, like that's not a thing. Like they're like, oh, you can change that. I'm like, yeah, that's what I do all day. And they're like, oh wow, I know so many people with pain, and we just thought that is how it is. So I think, again, it's all about having a dialogue, having a conversation. And I think that's why things like these webinars and podcasts are really important, to get that information out there so people realize it's not normal, or it doesn't have to be their normal if they don't want it to be.
Well, and I think on that point, Rachel, like this is happening to people of all ages, women of all ages. Can you talk a little bit about that? And then also, like, are you seeing younger women, older women, and then also men? Are men challenged with this? Because you work with both men and women.
Mm-hmm. Yeah. So, I always say that pelvic floor dysfunction is like the ultimate feminist. It can affect everyone, men and women. It doesn't, discriminate against one or the other, because all the internal muscles, the pelvic floor, are the same in men, women, children, everyone. It's just the external genitalia that's different. So men can have pain with erections, they can have pain with ejaculation, because again, if those, or they can have erectile dysfunction if those muscles have become restricted or they're dysfunctional, and those are the muscles that help with obtaining, maintaining an erection and ejaculation, it can lead to pain. So I'm treating men the same way I would treat women, treating the external myofascial restrictions as well as internally. And for women, I see people, or patients in general, I see patients as young as, teenagers up until, their 80s, 90s. So I see people throughout the lifespan. And yeah, anyone, we don't discriminate. Anyone can see us, and it affects everyone, or can affect everyone.
Can people do physical therapy at home? Like, are there some home things that women can do, or women and men?
Yeah, there are. It's obviously kind of hard to give recommendations just like off the bat, because everyone's different. What one person needs might not work for someone else, or can make things worse for someone else. So it's always hard for me to give recommendations of things you can do at home, but there are. We actually have a blog on our website that gives a lot of good resources. So based on what someone's symptoms are, they could go to our blog and look things up. pelvicpainrehab.com is our website. We also have a book, Pelvic Pain Explained, so that also gives good resources, so that way, someone could look and see like what sounds like me, and find recommendations off of that. But ideally, they should try to see a provider, even if it's just for a consultation, to get recommendations for things to do at home. But there are lots of things people can do at home. It's just hard to give recommendations, just a blanket statement. But our goal is always to have people be independent and not have to rely on coming to see me. We want them to be able to do things at home to help get them to a better place. So there are things to do at home, but I'm always kind of reluctant to give like a recommendation, just like, because everyone's so different.
Great. Before I open it up for questions, which I'm going to do in just a moment, on the devices, to Emily and to Liz, can you use lubricants of any kind, or can you talk a little bit about what is safe to use with the devices if attendees want to check out the Lioness and the Ohnut? So either one of you, go ahead and jump in.
You can go, Liz.
Yeah. Okay. Yeah, I think so. I know Lioness and Ohnut are made from different materials. So there's going to be different lubricants will interact with different materials in different ways. So for Lioness is 100% body safe silicone. So you can use any sort of water-based lubricant is totally fine. Silicone lubricants are kind of, I would not recommend it, because there's sometimes like interactions depending on the blend of silicone, of the lubricant, or of the vibrator. So I'd play it safe with that. And then for the one thing I will say that you should not use, or I would caution using with the Lioness specifically, is massage oils, or like sometimes like coconut oil, or like basically like the body massage oil that you might use like on your body. Some people do try to use on different sorts of vibrators. And that can, depending on the oil, it can cause the silicone to loosen sometimes. So we've had a couple like casualties of the prototyping process of like someone, trying to use massage oils, and it doesn't really do too much to the vibrator itself. So like you can still use it, but because because there's sensors inside here and there's pressure, it does loosen the silicone, so it can make the sensors less effective and less able to pick up on your body's responses. So that's the lowdown for Lioness, and I'll kick it over to Emily for Ohnut.
Yeah. So we started out with this 100% silicone product, and actually migrated away from that because it was important to certain clinicians in the medical community that it be compatible with silicone lubrication. So we converted it to a body safe TPR is what it's called. It's a body safe polymer that is compatible with silicone or water-based or lubrication. So you have that option. We're trying to make the product as minimally disruptive as possible during a sexual event. And silicone lube does tend to last longer. So yeah, we've adapted the product to be compatible with anything, really.
Great. Fantastic. Yeah. All right. Well, with that, I would love to check in with Shannon and see if we have any questions that have come in, or I'd like to invite questions from our attendees. So I'm going to pause for a second and just check in here with Shannon.
Hi, everyone. Thanks so much for all the questions that have been coming in. I think we've covered all the ones that came in through the Q&A. If anybody has additional questions, please feel free to enter them either in the chat window, or there's a Q&A button at the bottom of your screen. Jill, we also have those questions that came in beforehand, if we want to take a look at those while we see what else is new.
Great.
Thanks.
Okay, great. I'm gonna dive into those. One thing, I know a question came in and said, is there a directory of physical therapists? And Rachel went ahead and provided a URL. I think Shannon's going to put that in the chat window, of pelvicpain.org. So pelvicpain.org is where you can find PTs in your local area. So I'm going to just go to a couple of questions that were pre-submitted. One woman basically was talking a little bit about or deals with vaginal atrophy, and has been really struggling with painful sex with her partner through penetrative sex. And her physician put her on estrogen, but that created bleeding and growth in her fibroids. And so not working so well. So she resorted to Replens from a lubrication perspective, but it's not helped very much at all. She's just wondering, are there other options out there relative to the dryness that she should be looking at, and or just how they can start to improve on penetration not hurting so much? So first I'm going to go to Rachel.
Yeah, so I mean, I'd be curious, first of all, to know what if they just tried one type of a hormone replacement, because kind of like Dr. Kingsberg was talking about, there's tons of different options. So I'd be curious to know, what else, like what did they try? Because there are many options that might work better than whatever she tried. There is a product out there called Vital V. It used to be called Vital Vulva, but I guess vulva was not something people like to say. So it's called Vital V, and it's a yam salve. And yams tend to have similar properties to estrogen. So sometimes I have patients try that, especially if they're, they can't use hormones for some reason or they don't want to. And you can order that online. And that can sometimes help if they weren't able to tolerate actual hormones. But again, I'd be interested to see if there's something else they could try, because obviously there's a lot of options. So, and then there's tons of different lubricants out there and different vaginal moisturizers. So finding a really good water-based lubricant is sometimes really helpful. And again, I know not everyone, some people wrote saying they weren't able to get, they don't have access to a physical therapist. And I totally recognize that not everyone can, but if you are able to see a pelvic floor physical therapist, they can sometimes address what's going on with the pelvic floor muscles and surrounding muscles that might be contributing to her symptoms. So, trying to get a multidisciplinary care team is really important, working with someone like Dr. Zimmerman, as well as a pelvic floor PT. But I recognize not everyone has access to those people, so I apologize if, they can't. But again, there are a lot of resources, hence why I gave those websites. And
that's great.
Yeah.
That's great. Even for when it sounds like this individual has tried multiple options, tried the estrogen, tried the Riplens and the lubricants, and the pain still exists. Jessa, how do you recommend or advise? It sounds like her partner has been very, very patient, which is fantastic. But how do you help couples work through when they've tried different scenarios and they're just not working?
I mean, part of it may come down to grieving. Sometimes things happen that aren't going to get better. Whether it's pain or somebody's had cancer or somebody's had, a surgery or, sometimes there are permanent changes to our functioning, and we have to grieve that, So part of it really is adjusting to a loss, which I certainly want to honor and support. And then as part of the grieving process or at the end of that, or, at some point, it's about how great a sex life can we create with what we have, right? So again, we're back to changing sort of expectations and making the room bigger and trying to understand that there's still a lot of room for pleasure and connection with each other. It may not be able to look like what it used to look like, and I get that that's very disappointing, very hard, but it's not the end.
Thanks. That's an honest look at it. How about hysterectomies? Women who have gone through hysterectomies, Rachel, I have to think that you see a number of women who have had a hysterectomy, young and old, and then the ensuing painful sex that occurs or the dryness that occurs. Are there specific bits of advice or work that you do with women who have actually gone through hysterectomy that's different than if they had not?
Yeah, so I mean, other than the obvious like hormonal piece, which I feel like we've talked a lot about, depending on how the surgery was done, there can be scars. So if they have anything they can work on externally, that's something I definitely look at. And then, having that kind of a surgery, whether it was laparoscopic or not, or minimally invasive, the muscles again are going to be like, whoa, what just happened? We need to protect this person. And so they're going to probably go into like a hypertonic or contracted or spasmodic state. So that's something that we work on, is trying to get, again, those muscles to normalize, get them to relax. And again, getting them to just be in touch with their bodies, because perhaps they're having a hysterectomy because they've had pain for so long that now they don't really think about that area of the body. So sometimes working on doing like full body scans where they have to really focus on being in their pelvis and thinking about that area of the body. But mainly I'm going to be working on probably the myofascial restrictions that have occurred from having such a big surgery. And there are, for people like that, there are tools sometimes I recommend for them to do self-treatment at home. There's things like vaginal dilators that can sometimes be beneficial. There's something called a TheraWand, or I believe it's now called a PelviWand, to do self-treatment at home. And so it just really depends on the type of surgery, how it was done. But really, most people who've had that kind of a surgery are going to have some sort of pelvic floor dysfunction.
How about, can you comment on vulvodynia?
So vulvodynia just essentially means pain in the vulva. That's what it means. And there's, different types of vulvodynia. And depending, it usually is there's kind of different causes of vulvodynia, and you usually need to figure out what the cause is to fully treat it. But there's usually multifactorial causes of a person's vulvodynia. One cause can be a hormonal dysfunction. So again, if you treat that, there still might be things like pelvic floor dysfunction, as well as other things that need to be addressed in there. Sometimes it can be due to an overgrowth of a certain type of nerve fiber in the vaginal opening, and so that would require different treatment. Or it can be due to pelvic floor dysfunction. So if someone's having pain in the vulva, that could be the clitoris, vaginal opening, and it could be things with penetration, like inserting a tampon or having penetrative sex, but it could be all the time. Maybe they're having burning when they're wearing tight clothing or with sitting. So it can present itself in different ways, but usually it will require, again, a similar treatment approach for anyone who's having pain with sex, which would include, a physician who specialized in chronic pain, a sex therapist, a pelvic floor physical therapist. So it's pretty, whatever the diagnosis is, the treatment might be similar, but you still need to find that underlying cause.
It's great. I think it's such a mystery, and it's a term that just doesn't get used very much, but thrown around and not without an explanation. So thank you. I think with that, we are nearing the end of our time. I want each of the panelists to just take 30 seconds and address, your website, your product, where people can find your resources if you've got content or podcasts or products. I want to hear from, let's start with Emily around where can people find the Ohnut, then go to Liz, then to Jessa, and then to Rachel. So go ahead, Emily.
Yeah, brilliant. I actually just posted on the site and spelled professional wrong. You can order Ohnut on our website. It's a pre-order right now. Product will be available in October, which is very exciting. So www.ohnut.co. And it can point you to professional materials. We can send informational materials for your patients or clients, in addition to the pre-order capability. So, and we're on, all of our social media is at Ohnutco, OHNUTCO, Twitter, Instagram, Facebook, that whole thing. Yeah.
Fantastic. Thank you. Liz?
Yeah, so if you want to learn more about the Lioness, you can go to www.lioness.io, and LIONESS, since some people put in 2 N's instead of 1. And and we also have a 15% off for anyone who is interested in purchasing a Lioness of their own. So that code is Gennev. So if you type that in, you can get your 15% off. And yeah, I recommend looking into a variety of options, but I think masturbation ends up being a sort of like overlooked option for people for exploring or experimenting, or even like basically learning more about like what works for them and what doesn't, whether it's with the Lioness or with any other product. So I highly encourage people to, if they haven't already, keep exploring.
It's great. Thank you, Liz. Jessa?
Well, let's see. My website is jessazimmerman.com. I have a ton of resources on there. People could get on my mailing list for sure, because there's a whole flow of information that I send out. And like you mentioned, I do host a weekly podcast called Better Sex. So that's at bettersexpodcast.com. And then I guess I should mention the book that I'll be publishing in September. So it's called Sex Without Stress, A Couple's Guide to Overcoming Disappointment, Avoidance, and Pressure. So it really is for people that are struggling in their sex life and it's become a negative loaded thing instead of pleasurable. And it's really a do-it-yourself process to work through that. So that'll be available on Amazon.
Fantastic. Thank you. And congratulations on publishing that. That's great. All right. And Rachel.
Yeah, so our website is pelvicpainrehab.com. As I mentioned, we have a blog, lots of resources on there for people who, want to know more that they can do at home. They don't have access to a PT. That's probably the best place to go to get more information that's relevant to whatever's going on with them personally. And we have Pelvic Pain Explained, which is our book. Again, another great resource for anyone who maybe doesn't have access to a provider in their area. And then on social media for the company, Pelvic Health, pretty much is, I think, across the board how you can find us, or the Pelvic Health and Rehabilitation Center on Facebook. You're welcome to follow me. I'm Pelvic Health SF on Instagram, and everywhere else, Rachel G. DPT. And yeah, I think that's all.
That's awesome. Thank you so much, Rachel. And finally, thanks to all the attendees. I know we've had a few people drop off, but thanks for joining us for this very honest and personal conversation. I hope that you walk away today with something that is got you excited or gives you motivation or hope or something new to try. As with anything, you can always email us at info@gennev.com. Gennev has 2 N's, just to remind you. It's a confidential email, and we will direct you to any one of these incredible specialists. Or just stay tuned for information and links. Shannon's going to make sure that we have all of the resources that they just listed included with this webinar. And 2, if you are looking for safe lubricants, we do have our line of Gennev lubricants that have proven to help a lot of women. And so feel free to check those out. And with that, I just want to thank everyone. This has been an incredible, I think, educational and fun discussion. So thank you all. And I look forward to reconnecting in the future on maybe painful sex number 2. If we have more questions that come in, I think we should do this on a regular basis. So thanks, everyone.